thank you all for joining. It's very exciting to have everyone here. I'm Traci Green. I'm the Deputy Director for the COBRA on Opioids and Overdose at Rhode Island Hospital. And I'm delighted to invite and welcome you all to this panel. I'm co-moderating with my friend and dear colleague, Gordon Casey, who will introduce himself in a minute. But we're really happy to have the chance to welcome a panel from across the country to talk with us and engage with us in a conversation about harm reduction. And harm reduction as no more fundamental of a topic and a concept, and so relevant to today, to the opioid crisis, to addiction, and to framing a response, evidence-based and really socially just approach to thinking about drug use, substance use, and how we might be able to change how we approach treatment, prevention, recovery, and rescue responses. So we're excited to talk about all of these things today, and we'll look forward to having both comments from our panel. We've kind of sorted a collection of questions for them, and then also to open it up to the attendees at the latter part of our conversation. So without further ado, I'm going to introduce and allow Gordon to introduce himself.
Thanks, Traci. Yeah, hi, I'm Gordon Casey. I work in Vancouver at a place called the Brave Technology Co-op. We're a technology organization, a cooperative, so we're owned by our workers and investors, but also by our end users, who are, of course, people who use drugs. We're trying to prevent accidental overdose through various means, and we're informed completely by the experience and ideas and lived experience of the folks who use our things. We like to think of ourselves as the sort of tech arm of the harm reduction movement. And one of the things we've been grappling with, and why I'm so excited to hear from everybody here today, is what is harm reduction, or what's the end game, if there is an end game. And it's fascinating as I've had the privilege of traveling around conferences and speaking to people, how that changes depending on where you are at, and how, for instance, the things that happened in Oregon last week, could be seen as a massive end game and a massive win, but that's still not it, right? That's still not the end. So that question I'm really fascinated by, and want to hear what people have to say about what harm reduction is and what it means to be part of this. Thanks, Traci. That's me. So should we allow our panelists to introduce themselves?
Yeah, and so we've asked people to go alphabetically, and really please welcome, and we'd love if you could take a minute to introduce yourself and sort of let us know what it is that your role is in the framework of harm reduction, and sort of what's your fit within the harm reduction landscape. Please.
Yeah, so I'll go ahead and jump in. Yeah, thank you all so much. It's great to be speaking with you all today. I'm really honored to be on this panel. There's a lot of pretty big badasses on the panel today. So I'm, I start my beginnings as a small town Iowa boy who somehow found himself in DC doing harm reduction work with an organization called HIPS. Later, sort of working through more HIV, hepatitis C policy at organizations like NASTAD, and then somehow found my way back to the Midwest. I just kind of swore I'd never come back to Iowa, but was later working for the Iowa Department of Health in the development of a drug user health program, and really trying to fashion what that will look like, especially in a state that doesn't have legal syringe exchange. And also at the same time where there's really, really incredible work happening sort of underground through organizations like the Iowa Harm Reduction Coalition, or the Quad City Harm Reduction Coalition in Iowa. And so was working on that a couple of years, and then brought sort of those lessons that I learned there to the Rural Drug Addiction Research Center. And so excited to be back as an affiliate, but where it helped out sort of with the rural health cohort study, and really one of the first studies of its time in this region to really engage people who are still using drugs and sort of, again, navigate some of these social determinants of health that they're navigating to access care. And today I'm still working sort of on a volunteer basis with University of Nebraska-Lincoln while I pursue school at the University of Denver, Colorado School of Public Health. We're doing a statewide survey with behavioral health practitioners on attitudes around harm reduction currently. So I'm really excited. I think where I fit in this is trying to figure out, really how ready are our systems, and especially in states like Iowa and Nebraska, to ramp up support for harm reduction programming in those jurisdictions. So really excited. Thank you.
Great. Welcome.
So I guess that's me next. Hi, everyone. I'm also extremely honored and really humbled to be invited to this. Really in awe of the people in front of me and the people on the ground doing just amazing work. Also, with at the same time as dealing with so much loss and uncertainty and unrest in their communities. So I just want to give a shout out to those folks. And send some gratitude their way. I'm Dave Lucas, and I'm a social worker by trade, and I'm a clinical advisor currently at a nonprofit in New York City. My work is focused on substance use treatment and harm reduction, specifically kind of in the criminal legal system landscape. Prior to moving to the US, I was an addiction therapist at a hospital in Toronto for about 10 years. And again, there I worked mostly with people who were caught up in the legal system. In the last couple of years there, I was also involved with the Moss Park overdose prevention site in its early days when it was a tent and then a trailer. So that was a pretty cool moonlighting experience. I was working kind of with the court system during the day and in the community in a legal site at night. And that was a real turning point for me in kind of the harm reduction world, I have to say. Again, really, in awe of the folks who got that, I carried their water, these amazing activists who got that going there. And so that was a turning point for me and really kind of galvanized kind of my efforts in this space. So all to say that my space or my role in this landscape is an odd one. I think of myself as a clinician, but most of my work really is just trying to convince court actors to understand harm reduction, to embrace it, to think about trauma and racial disparities. And, it sometimes feels like really incremental work, but there's a lot of people in the system right now who are facing these harms. And so my thinking is try to address those harms while we work at the same time simultaneously to dismantle these systems. So, as Gordon said, the long game, get substance use out of the courts, out of the legal system. I'm a social worker. The long game for me is be out of work, right? So I would be happy if I lost this job eventually and had to, start cooking somewhere. So that's me. And I'm, again, just so stoked to be a part of this. And it's great to meet everybody.
Fantastic. Look forward to meeting or hearing more. Yeah. Ju, please.
Hi. Hi, everyone. Just want to echo what has already been said. Thank you so much for having me. And it's great to meet everybody on this panel and talk to you all. So I am a epidemiologist. I'm a harm reductionist and faculty researcher at Johns Hopkins University. I'm currently based in Baltimore. If you can tell by my accent, I'm originally from Australia. That's where I entered the world of public health. And when I moved to Baltimore, I got involved as a student as a local organizer and volunteer for local naloxone program, as well as some legislation. And I have been here for now 8 years. A lot of my research and teaching focuses on harm reduction and substance use more broadly, and I try to conduct work that helps to shape policy, and actually recently has started providing testimony at the state level as well on drug paraphernalia decriminalization and hopefully drug criminalization very shortly. But I'm just really happy to be here and just participate in this discussion.
Excellent. Natasha.
Hi, thank you for having me. I'm also very excited to be here and to be amongst you. My training was in clinical psychology. I'm a professor of human development and family science at The Ohio State University. I've been working with homeless youth and families since 1996. So my work has focused on developing and testing interventions, prevention interventions for these youth and young mothers with substance use disorder, and working towards reintegrating the youth into our social fold. currently, my team and I, including Kelly Kelleher, who's a pediatrician at Nationwide Children's Hospital, were funded on a trial to test the opioid use disorder prevention intervention with youth experiencing homelessness, because these youth are some of the highest risk population for opioid use disorder and overdose, and they're often left out of research and intervention trials because they're hard to identify and access and engage and all of that. So Kelly and I and our team are working to identify and engage and test interventions to get them off the streets and to prevent opioid use disorder. So that's me.
Fantastic.
I guess I'm the last.
Haven, go for it.
So I'm Haven Wheelock. I don't quite feel cool enough to be on this panel right now because there's a lot of very, very smart humans on this call. But I have been working in direct service harm reduction programming for almost 18 years. So I've been doing syringe services, direct services since 2002. Before that, I was doing HIV prevention work. So I've got like more years than I like to admit. Like 1998 was when I first started doing HIV prevention work. So I've been in this game for quite a long time. I love people who use drugs more than any other people and would trade most normies for clients of our syringe exchange any day of the week. I have also been involved with some state level legislation, drafting our naloxone policies, our Good Samaritan policies. Most recently, I was a chief petitioner on Measure 110 that decriminalized all drugs in the state of Oregon as of last week. Additionally, I completed a fellowship at Johns Hopkins University, getting my master's of public health with a focus on addiction and recovery, and been able to do some research around hepatitis C stuff. We just actually had a paper published today on severe bacterial infections amongst injection drug users in the state of Oregon. So my research toes are like dabbling, but I'm not quite to the level of some of y'all. But I'm excited to be here and to like offer my 2 cents and my thoughts.
Super. Thank you. So as you can see, we have 51 attendees and counting at this wonderful panel. So we look forward to an engaged discussion. But first, we have a couple of questions to head us off. Gordon, do you want to start it?
Yeah, sure. So I think we can sort of go in rounds with our thinking, and to try and, given that there's quite a few of us, and to try and be relatively quick and maybe pithy. But there's been so many threats to, or there are so many threats to harm reduction, historically, currently, and whether it's just logistically or the financial support we receive, the political mandates that people are willing to offer that you're fighting for, and medical as well. Today, I think, and I know that it's very different depending on what your geographies are, but what do you feel are the major threats to harm reduction today? And maybe what are some of the blind spots that we're facing as people are trying to move harm reduction forward? And perhaps maybe as another prompt, you don't have to answer all these questions, but as another prompt, maybe what's the life raft that we have in the face of these threats? And I'll let it be adults for a minute and see if anybody's feeling the urge to speak right away, and you can raise your hand or just unmute yourself and start. Thanks, Natasha. Go for it.
Well, I mean, I think that what I see as maybe one of the major threats today is the pandemic, which is associated with the major economic downturn. And so, for example, in Ohio, Medicaid is announcing a multi-billion-dollar shortfall in 2020, and the state of Ohio is expecting a shortfall of $8 billion in the coming year alone. So, and that can be extended now for the next 3 years. COVID is really a whirlpool that's going to draw attention away from substance use disorder and homelessness. While they both make substance use worse. Like it's a horrible situation that I think that we're in. Makes recovery more difficult because we can't come together physically as a community to work together with those who are suffering. Also, emergency food aid, rental support, lawsuits, violence prevention. These are all going to take center stage with philanthropy and government and not-for-profits over the next 5 years. I think a life raft is, I think that harm reduction might be inadequately linked with these core, less stigmatized initiatives that address like social needs like housing and food. We could do better with that, perhaps.
Yeah, thanks, Natasha. Yeah, and I know from the statistics, Ohio, like everywhere else, that is getting up-to-date data. The overdose death numbers have soared in the last 6 or 7 months, which is, yeah, it is. And who would like to answer that question as well?
I'll jump in here real quick. So yeah, I in the past when I've introduced myself, I always say recovering bureaucrat. I feel like I've sort of recovered a little bit, so I can a little bit more open to speak a little bit against some of the systems I've worked in. And so I think one of the biggest concerns I have is sort of this trend that we're seeing with the integration of health services. I think there's so much in terms of efficiency and wraparound services that I think we want to highlight in the integration of these services. But I think in states like Iowa, as an example, or Nebraska, which are sort of in this process of integration of the human services system and the public health system, we see sort of this lack of accountability of the security of a lot of the participants who are engaging in these programs. And what I'm specifically thinking of are mothers who might be engaged with DHS systems who are now accessing HIV and hepatitis C preventive services. What are the sort of unintended consequences of these new data systems being able to speak to one another, especially in the safety of folks who are using drugs? And I think this can further be exemplified by, especially in Iowa, law enforcement having access to prescription drug monitoring programs and things like that. And I think that as state governments want to lean on these sort of, not necessarily silver bullet solutions, but what's happening around the country, we have to be really cognizant of some of these more local environments, especially in conservative states like Iowa and Nebraska, about some of these unintended consequences with that too. Life rafts, though, I am super, super excited about everything going on in Oregon. I just have to highlight the fact that South Dakota flipped to full medical marijuana legalization because, we're talking about a state that was, I think, existing in a plane that people could get charged with drug possession for having drugs in their system, right? So that type of switch, even though we're not quite to drug decrim in the Midwest, like we are out in our friends in the Pacific Northwest, I think that there's some places to highlight there too.
Mm.
I guess when I hear this question, like, what are the threats to harm reduction? I feel a little differently. And like, to me, the biggest threat I see to harm reduction is less about the movement, because I think the movement and the professionalization of harm reduction is going to keep going. We're still going to have researchers. What actually scares me is the level of burnout, heartbreak, like exhaustion that those of us that are like providing services every day are experiencing pre-COVID and now so very much so with COVID. Like, my program has 3 staff. Historically, we would have 12 volunteers that we can't have in our space now because of COVID. So we're all doing the work of 4 people while still confirming deaths on people we know and care about, while not being able to like reach out to our community, like not having a harm reduction conference this year and not getting to hug all my people. Like, and I really am concerned, like, less about the movement as a whole, because I think people are starting to accept harm reduction as a valid part of healthcare, as part of the continuum of care for services. But the theoretical can't exist without the actual people doing the work. And I'm really, really concerned for my colleagues who are on the ground every day, losing loved ones on the regular. And like, how do we make sure those folks get the space and the healing that they need as well? And the life raft for that is just like hug on each other as hard as you can, even in virtual spaces, I think. And just remembering that it's like, I think for me, I get super frustrated in harm reduction, like conversations, especially when it's not direct service providers, because frankly, like literally I confirmed death on 2 people today, right? Before jumping on this call. And these are real life people that like I've hugged and I've known for a long time. And so, you know, how do we as a movement of intellectuals and theorists, how do we make sure that those folks that are still handing the naloxone to the person are getting the supports that they need?
Can I comment on Haven's comment? I agree with Haven. I think that's a really important point. And I think that our mental health service providers, substance use providers in this country are overtaxed. For one thing, there's not enough in order to address all of the need that we have. I think we might need to move away from the guild model where everything goes through licensed professionals or from doctors to nurses to pharmacists, and instead start looking at non-licensed professionals to help us. And this is done, I believe, a lot more in other countries. But it's something to consider for delivery and partnering to increase access to services for many of those who don't have access, and to reduce the demand on the small number of service providers that we have who are getting overwhelmed. Sorry, okay. I'm going to have to control how much I talk, so.
I just want to say something really quick in response to what Haven said, and I just want to echo the importance of that and make sure that we kind of keep circling back to the people at the heart of this who are you know, boots on the ground, but also experiencing that grief and that trauma that we don't even understand the fallout. We don't understand the COVID fallout. We don't understand the overdose fallout. And most of the folks I think that Haven's talking about are not just working with people in syringe exchange, you know, or you know, these are in housing encampments and they're homeless folk, people in shelters. So they all of those intersecting risks every single day. And, you know, I talk with some friends back home in Toronto who still 3 years after starting to ask for support for, you know, grief support, don't have it. There's nobody stepped up to say, we're going to provide a space for you to meet and provide some care. So I think that I also want to add, you know, Natasha brought up more informal kind of responses. Yes, peers, but we don't pay peers, right? So not only are we overburdening them, we're not paying them. And so we're downloading, and it's kind of not really transforming the system, really. It's just back where on the shoulders of the folks it's always been on. So I see kind of our peers as a life raft. I see them not paying them as a blind spot. And I see not taking care of our people as probably the major threat, because as our field gets more professionalized and medicalized and technocratic, and every field now has a harm reduction toolkit on their desk, the same people who are, you know, doing what Haven was doing earlier today are going to be burdened in kind of those same ways. So I don't predict a trickle down without, you know, some real direct action there.
Yeah, I agree with everything that's been said. And Haven, when you bring up, you know, burnout, I think of grief and the mental health aspects of all of this. And I also work with peers out of a recovery program at Johns Hopkins, and they are just amazing and instrumental. And it's unbelievable that they are grant funded, and we don't really have a mechanism to continue employing them. And so whatever we can do on the policy side, I think, to sustain public health funding, but also this type of harm reduction programming, which we know is just so instrumental to serving the people with addiction and who are living with using drugs. And so I think like all of this is so important. I also think that a life raft could come from research, just because there has historically been quite a lot of substance use funding, but more so in recent years. And I do think that researchers have a role to play. And so how can researchers be more inclusive and build those partnerships so that what we do isn't always just so theoretical, but actually helps the situation on the ground? I think it's something we all need to think about.
Yeah, and I think, Ju, your comments maybe are a good segue into the next question we really wanted to ask you all, which it's certainly the threats and the barriers are many, and they're going to stay with us for some time. We're all collectively experiencing the trauma that is, have been experiencing the trauma that has been the opioid crisis, and continue to now, as a society, kind of wade through what is COVID-19 and what is it going to mean for everybody. But I think also it comes perhaps opportunity, and perhaps these are changes that fundamentally may shift society for us to think differently, and to approach maybe harm reduction as a practical and thoughtful response that we don't have, need to be considering. So I'm wondering, in thinking about harm reduction, if there are partnerships and different kind of synergies that can really bring about the kinds of change and really lasting change that are really needed at this time. And, you know, in this case, really thinking about how do we identify partnerships and synergies for harm reduction to leverage this opportunity, this chaotic time too. And I guess maybe I'm going to ask Haven if it's okay, because I feel like you've nailed this one, or at least started us in this direction of like, how were there partnerships and synergies that were unexpected in your endeavors in Oregon with respect to decriminalization of illicit substances in the state? And were there any lessons from that? And maybe from everybody's perspective in the sides of the country that you're in, do you see some unusual partnerships that we as a research entity and as a collective group thinking about harm reduction should really try to foster?
Yeah, I mean, when I think about like all of the people that came together on Measure 110 and the work and the support, like the really broad base of support that went into that initiative, it's really, I was blown away. Like the Oregon Food Bank endorsed, right? Like, and it makes sense if you think about it in terms of like addiction is crossing all kinds of barriers, right? And like there's not like one demographic, but we know that people who are struggling struggle harder when they struggle, right? And so, you know, I think being really open to understanding where people, like, I know I personally like get kind of like defensive, right? Around like who's at the harm reduction table, right? Like, and like, does my definition of harm reduction align with their definition of harm reduction? And one of the like lessons learned that I had to do working on this campaign was, one, normies don't know what harm reduction is. Like we actually did polling on it. They literally don't know what it means. So like really thinking about how we frame the work we do is really important. Like a full continuum of care for people who use drugs. That is a sentence I have said more times, right? It's like, in my mind, I know I'm talking about harm reduction, but people understand it better if I don't use that word. And so, you know, really thinking about like, it's okay if we don't all agree on all of the things, right? As long as we're all moving in the same kind of direction. So, I mean, we've had a lot of like criminal justice reform partnerships, a lot of like healthcare partnerships that we expected. But I think like the energy in general is just everyone knows it's really bad and that we need to like kind of do more. And I think COVID has presented some really unique opportunities with that, right? Like when you think about like the rules, like the SAMHSA rules changing around medication for treating addiction, right? Like methadone clinics, instead of making you come every day, are now letting you do weekly takeouts, which makes it so much easier for folks to start medication for their opioid use disorder. We've been able to partner with a bridge clinic, and I can actually get people started on Suboxone same day from a tablet in my office. And mostly for folks that don't have their own technology, right? Like, you know, for a lot of folks, doing online doctor's appointments is really great. And it is if you have Wi-Fi and you have a phone. So like being able to like streamline some of those processes so that we can just make it happen easier for folks is something that feels really different with COVID. And I really hope our changes we can continue to have in a post-COVID world if we ever get there. You know, like there have been some significant changes. We were able to change our 1-for-1 policy in our syringe exchange because of COVID, and now do needs-based distribution of both syringes and naloxone, which was something I've been fighting for nearly 20 years. And so never let a good crisis hold you back. You know, the state of Oregon also is using COVID funding now for harm reduction services, right? We were able to get funding specific for things like meth pipes, because you know what's a good way to spread COVID? Sharing a pipe, right? And so I think, you know, there's some room to like be a little creative with how these things play out too, which I'm excited to see what other places are doing and how we can best leverage some of this like energy going forward. And I don't know that I answered your question. I think I just got on a soapbox.
I heard lots of synergies there. A lot of broadened partnerships. That was great. Other thoughts? I'm curious from all different, you guys are representing such different parts of the country too. So I'd be really interested for Joe and Natasha in particular from Ohio and Iowa sort of perspectives, if you are experiencing, not necessarily in COVID, but along your way have seen different synergies or ones that we haven't yet tapped.
Yeah, maybe businesses and technology companies. I think that technology and artificial intelligence can really help us manage risk. And I don't know that we have adequately engaged businesses and technology companies to help us. And there may be innovative ways to do that, like coming up with strategies on return of investment. Things like that. So I think maybe businesses, technology companies are partnerships that we haven't capitalized on as much as we could.
Yeah, I'm going to say substance use disorder treatment centers, and I recognize in the harm reduction space, what that can mean, especially with this legacy that I think a lot of centers have had on people who are using drugs. But I think given the reality, back in Iowa, when advocates were really pushing for the legalization of certain service programs, legislators were often always responding back, okay, so how many people, like what percentage of people who are going to be going through these programs are going to be getting the treatment, right? The end goal still is always on treatment. And so, I think that, and this is going to probably be, I'll echo this, I think that yes, people are dying, and there's nothing I can't say but after that statement. People are dying, right? And I think that given the structures that we have in places like Iowa and Nebraska, where we're relying on substance use disorder treatment organizations, many of whom are starting to use language around harm reduction, at least in accessing funding, so that's a starting point. I think that if we're able to slowly start shifting this definition of what recovery means, right? And if we're starting defining recovery as stability and addressing other, again, wraparound needs of individuals, then maybe we're going to be able to meet substance use treatment industrial complex where it's at, right? I think, but because of the way that we've just seen SAMHSA dollars, HRSA, CDC dollars going down into these state block grants that are not held accountable for really outcomes, right? I think we're going to have to figure out a way that we can sort of slide harm reduction in there, and then again hold some of these centers accountable if they're going to preach it, right? But I am hopeful. I don't know if we have necessarily the history of that success, but I think it's the only way we're going to move forward here in the Midwest, at least, unfortunately.
I think if we can reward outcomes with payments from insurance and others, rather than the volume of services, that really would create a commitment to quality over quantity. I think that's super good idea.
Drew or David, any thoughts on the concept of synergies and partnerships, perhaps, that successful partnerships that you've seen or been part of?
Well, this is a really good question because I can think of a lot of examples of synergies that haven't worked out well for us in Maryland. But in terms of synergies that have worked out, or synergies or collaboration partnerships that I'd like to build, I think we are at a historical moment, not only for overdose and harm reduction, and of course, like the COVID pandemic, but also racial justice. And I know that in the harm reduction community, there has been a shift and a greater understanding of the intersection between racial justice and drug policy. So I hope that that is a partnership that can help, where there is commonality and goals, help move us forward in terms of the policies and the laws that have really disenfranchised Black and Brown communities for a long time. And we've seen it locally in Baltimore, and I hope to see more of it across the country as well.
I think in the last year or so, I've thought about language in this world more than ever before, and I've thought about treatment quality or lack thereof, and so my response is, I think the first thing about language, going back to what Haven said about, I know what I'm talking about, and I got to think about different ways. So one of the bulk of my work these days involves working with states. And I work with a lot of conservative states and there's two barriers there. A lot of conservative states don't want to talk about harm reduction, and and also my funding doesn't allow me sometimes to use those words full stop. So public health, therapeutic alliance, wraparound services, underlying health determinant, like there's a lot of workarounds, but you do sometimes wonder if what's sacrificed when you kind of change the movement and you take out some of the soul of that movement, and you do worry that it turns into kind of like these practices and strategies that are also easily co-opted, right? Trauma-informed care, somebody mentioned, we've talked about, lack of accountability. The amount of things you can call trauma-informed care that aren't, and yet you'll shut down a syringe exchange. That is the most, I want to swear right now, this is the most trauma-informed practice we have in this space right now, and we still can't get naloxone and syringe exchange out to our people, across the board. So language is an interesting one because it can be co-opted so easily, but yet we also have to work with it in order to engage different groups. I was thinking when I looked at this question, I thought, okay, so what are the professions I'd like to see for harm reduction in front of? So I was thinking like school teachers for harm reduction, or housing first for harm reduction, or red states for harm, but then I thought, okay, so what could harm reduction, the movement, maybe learn from and ally in, so that there's like a kind of a bit of a synergy. And my partner works kind of in the end of life care world, and certified death doula, and I've learned so much about that world. And I really feel that's, I think, why Haven's point about grief and struck me, because I think there's a natural, maybe not in terms of changing policy, but in terms of like learning and being able to kind of lean on each other a little bit. That's a partnership that I or an allyship that I think that could be really valuable for harm reduction. Also, the faith community, I think it's sometimes tough. Harm reduction sometimes stigmatizes the faith community because a lot of folks have had really bad experiences in the 12-step movement, so I get it. But we also know that, ministers for harm reduction could go a long way in certain communities, right? And we know that a lot of the movement in Portugal started with churches and syringe exchanges and shelter. There's a lot of overlap historically. So I think we need to bring that group in, and it's and I think that there's a lot of potential there. So I'm hopeful that that those partnerships will expand in the coming years, especially now that we can start saying, talking about things. Now that, the White House executive order, I don't know how many folks were affected by that executive order, but, for a couple months, I wasn't allowed to say the word racism in my work. So things have already changed even in a couple days. So I'm a tiny bit hopeful.
Haven, you look like you were about to say something. I didn't want to.
Oh, no, I was just thinking about like the whole grief doula and like where that partnership comes in. I think we're like, I've also often like thought that like, while I don't like it because it feels icky, but like we are completely okay with someone being like, I'm at the end of my life. I've lived a good life. How do we help you be safe and comfortable through the end of that? And I think like for me, harm reduction falls kind of in that bubble sometimes. It's like, it's not about curing people from something. It's about helping people be happy, healthy, and hopefully not dead, right? From their addiction, acknowledging that addiction can be a fatal illness. And really like, so I appreciate like that there are probably lessons we can learn from the hospice community, from like this end of life care kind of thinking that may help sustain us as providers to some extent, but also help us shape how we talk about addiction. And not all drug use is addiction. I'm not saying that at all. But for many, like, this is going to be their reality for their entire lives. And therefore, what can we do to make it okay and to help keep them safe? And that's really the work we're trying to do, is like uplift that like dignity for folks and that safety for folks. And yeah, for many, like they will stop using, right? Like, but that doesn't need to be the goal. Yeah, that's all. That it was just, David, you said that and it like struck a chord with me. So I wanted to like say that.
Hey, well, this is extremely rich in thinking about the constellation of people who are both at the table and perhaps on the periphery to bring closer. And I mean, we're the three entities involved in this week-long symposium are all researchers. They're research entities, and we have mechanisms for clinical trials and mechanisms for pilots and feasibility studies and this and that. So, and as a harm reduction researcher myself, I do find myself wondering all along with these tools and with this capacity, we're very lucky to have to also be a partner at the table and to be able to convene and bring you all together to talk and generate these new points of light. I guess I'm wondering then, kind of given these sort of threats and perhaps some of these opportunities, and these opportunities too for stitching people and organizations together, where, as researchers, where should we go? What are those key places to hone in on for and other innovation needs? I mean, not every good idea needs to be researched, but perhaps, and Gordon is full of great ideas, and some of them we should research and others we should just be doing and supporting to grow. But what are your thoughts on that? We'd love to hear from you. Key research areas.
Who wants to research implementing DCRIM? Like, what are the, I mean, that's a big question, right? Like, what are the outcomes that we are expecting to get out of DCRIM? I mean, I can label the like less people in jail, less overdose, more people having access, but there are other outcomes that we need to like think about and like that should be measured that we might not know the best way to measure at this point. I definitely don't, because I'm not that kind of researcher, but Sorry, that was kind of a quippy answer.
No, I'm hearing taking advantage of the natural experiments that we have, and you all have, Oregon has presented itself as a state as one that's at the county level, at the community level, at the individual level to really measure the impact of a pretty profound social determinant and structural impediment to health and safety, drug-related safety. Natasha.
Well, I think that much of the research that's out there on harm reduction and interventions to prevent ongoing risk and homelessness, et cetera, is focused on those who are accessing services or who come in to see us. And I think there's very little research, very little information, very little guidance on how to really find and engage those who are unengaged with the service system. And I believe that's the majority of people. So don't only 10% come in for help. So there's 90% of people out there who suffer that we're not finding because we don't have the workforce. We may not be trained to, I mean, we need a workforce that's able to go out there, to find them, to work with them who are capable to intervene and help, and research to support that.
I think to Natasha's point, and this is actually, I think, a point that Cassandra from DPA brought up, which was a really, really great talk for those who were able to attend. But engagement with folks who are using drugs that don't fit the criteria of problematic or abuse, right? Which is the majority of people who are using drugs in the first place, right? And so, what can we learn from individuals, right, of this experience who don't feel the need to be accessing these services, to Natasha's point as well, but also aren't necessarily viewing their drug use as a problem and are existing, which is again, the majority of folks. I think this goes again to the sort of refocusing on language around this being an opioid epidemic or an opioid crisis in favor of language that sort of identifies this as a drug poisoning crisis, for so many people. Shifting some of what we rely on, like prescription drug monitoring programs, are not going to give us this sort of greater picture around how people are dying from some of these substances, right? And so, yeah, that's sort of my contribution there.
I would just like to kind of wish upon a star selfishly that we had more research on what new treatment models, like actual kind of modalities, could look like in that kind of group space and that one-on-one counseling that really infuses harm reduction, or is maybe not infuses, but is built out of harm reduction principles, so that those conversations are not really about drug use. They're about other things. Your interaction with them is because they've arrived there maybe because of drugs, but working with folks who were in my group rooms because they were forced to by the court, I worked with a lot of people who used crack twice a month, but they were otherwise homeless and unemployed and dealing with mental illness, but they were in drug court, because of the charge. So sitting there and doing CBT with somebody to think about their thoughts and emotions, and that's not actually what they need. They talking about their environments and their world and their that's actually what brought folks back. And I just wish, and I'm not even saying I did it well, but I think just not doing it the same way as they were forced to before was different for them, and maybe refreshing, I hope. And I think I just wish we had some research on that. Like what are people doing to incorporate kind of like a social justice lens into addiction treatment models, because I think it's time for that. The conversation often stops with, we need to get people into treatment, but nobody really, besides medication, nobody says, well, what's good treatment? I mean, we still think it's CBT. We still think it's MI. We only think it's the things that have been researched. We don't know anything about the things that are not researched, right? And that to me just kind of drives me crazy. So that's what I want some dollars thrown at, if possible.
That totally reminds me of an NIH grant I'm hoping will be funded in the near future. I think treatment just looks different for so many people, and we haven't really done enough work on the preferences of people with lived experience, people who are actively using drugs, especially those who are using recreationally. And your work reminds me of just a very simple but yet very stigmatizing question that's still in many SAMHSA programs across the country. If anyone's familiar with CSAT, it's a type of substance use program that funds, services. And there's a question that says, how many days in the past 30 days have you committed a crime? And if your answer is less than the number of days you use drugs, it stops you and says, and asks the question again. And that's just another way for patients and people living with lived experience to be, stigmatized and just treated in a different way. And I really do believe that if we had better partnerships and actually people who use drugs just at the decision-making tables, developing these programs and policies, we wouldn't be seeing things like that happening across the country.
I have to admit, and a lot of what everybody's saying, it makes me think of the person looking for the keys that they lost under the light, right? That old joke, the cartoon. And I am biased, but it does also sounds to me a lot like what people are asking for is funding and a mandate to do innovation. And that is often missing. And there's a chicken and egg situation there, I think, for, we can only fund the things that we know work to a certain degree, but what's really, I feel, again, I'm biased, what's really needed here is capacity and space for innovation here, not just in the form of technology and in all forms. And we do want to hear from our audience who posted some questions already, and I'm sure there are more to come. Before we do, a sort of closing single sentence or maybe two sentences of what you would like to leave people with as we close this panel. We're not quite closed yet, but sort of as we're sort of signing off and going to group questions, or maybe as we're continuing through the rest of the symposium. Again, I'm not gonna pick on people, but I did notice that you still have your mic unmuted. So if you're willing to go first.
Sure. I would say there are a lot of opportunities to be involved. So if you're a student listening, or somebody who's not fully in the harm reduction movement or space, and but are very interested in the area, I was really fortunate to have those opportunities as a student to help advocate, to help develop programs, and actually the research that I worked on with Lisa Ma's group back in Sydney was very harm reduction oriented. We ran a secondary syringe exchange out of our research van. So I think like there are ways in which all of us can contribute, and there's just so much work to be done. So I really encourage everyone to get involved as much as you can. And if you are a person in a position of power or able to create those opportunities, then please do so.
Thank you. Who'd like to go next as a closing thought?
I'm going to be extremely pointed with this, and I apologize. This isn't going to be full of wisdom, but it's going to be directed a little bit at the folks in Nebraska. I know that there are some people here from the state DHHS. Because we don't have the overdose numbers, really to continue to make the case for the need for expansive naloxone programming, our syringe services programs. Demand state DHS provide hepatitis C numbers by county or by region. We really need those data. And for folks who are here at DHHS, you can do work internal to the state to release those numbers. Please feel free to reach out to me directly, and we can talk about some good ways to do that too. But thank you so much for the opportunity.
Thanks, Joe. Natasha?
I would say, I guess my thinking is to consider that harm reduction is more than just intervention focused on the individual, but that the family plays a huge part. We find engaging family members in prevention interventions they synergize our hoped outcomes to make them more powerful. So for example, mothers who have opioid use disorder, whose 8 to 16-year-old child participates in intervention with them, show greater opioid use reduction. And then the children themselves show delayed substance use. So that's one thing, and not just family, but community. I think we often forget to think about all of the other factors that influence the use of substances and other risk behaviors of our youth, of our folks that we serve. And also announce that prevention is worth a pound of cure. Let's start with our young people and the children of those adults that we serve.
Thanks. Thanks, Ava.
I think for me, like what I always kind of hope people take away from presentations like this is like, there's nothing special about any of us on this call, right? We are a bunch of people who care a lot about a thing. We're stubborn enough to keep coming back, even though it hurts and it sucks. And we do have the power to like create new, better systems and to create change. And so I think so often like people who are new to the movement look to people like who've been around forever as like somehow any different than like the scrappy 20-year-old I was when I first started in this movement. Like I'm still that like formerly homeless kid who's like punching up, trying to like get through things. And like, I think part of what I have seen really happen over the years with this movement, it has grown and we've created this like really big bench, and like acknowledging that we do have the power to make changes both in our movement and in our society and in our policy is something that I think people forget a lot. And so like, I like to like encourage folks to be brave enough to say, hey, Nebraska, we need your Hep C numbers, right? Like, it's okay to be stubborn and bossy and ask for what you need. And I encourage anyone to like really do that and be brave, because that's the only way we're gonna change this shit.
Amen. David?
I love that. I wish that was the closing point instead of mine, but I'll just try to jump off of it and say, be stubborn and be bossy and demand things. And at the same time, as we're doing that and as we stay strident and really kind of and keep shouting, I think, you know, we're good with our clients and our friends and our peers in this field when we know that they have trauma. We're not so good when we talk to people who are resistant to what we want. And often that's also because of trauma. And so I think sometimes our energy in the one direction is outstripping our, you know, our pause with the folks that, you know, we wouldn't yell and scream at our grandmother across the table about believing in harm reduction. We kind of need to figure out maybe well, I don't know, depending on what they say, but, you know, I think we just need to figure out how to pace those things at the same time, because they're both important. And so many of the people who are resistant, sometimes they're drug users too, right? Of course, for good reason. So we need to remember, you know, think strategically about how we're bringing folks along as well, that it's not a cool club, as kind of Haven was, you know, it's not a cool club or a smart club. It's like, it's kind of just built out of love. And if you got that, then you're welcome. Yeah.
Fantastic, everybody. Thank you. I'm just going to go through. We have 4 questions to date, so I'm just going to sort of run through them. And this is Gail, by the way, from the opioid Cobra. Kate Templeton, she comments and asks, I live in West Virginia near Huntington, and I am concerned about what Natasha spoke about. Our area has little money and lots of problems. We are overwhelmed with drug issues here. I want to help do what I can as a citizen in this area. What do you suggest for a starting point as a community member? I do have some insight because my daughter and son-in-law are recovered for several years.
Yeah, it's really tough. I think we're going to be in a tough situation, and identifying strategies to increase funding for us to continue our work and to serve those in need is going to be of primary importance. We can figure out how to link on to where the funding is going, like Haven talked about with COVID, innovative strategies to link substance use and COVID, or other strategies, and like working with businesses, I think that we'd have to get creative. I don't have the answer, but I think we definitely have to get creative.
I'm also just going to jump in that it's also can be very small scale, right? Like, yes, getting that money, right, for the bigger picture is really important. But, you know, like if you're in your community and somebody is struggling, say hi, right? Like acknowledge the humanity of the people in your community who are using it. It goes a long way for folks, right? Like I hear all the time from folks that they just don't feel human because their community doesn't see them as human. And so, you know, I don't know if the question was specific, like what can I do in my community? The number one thing you can do in your community is be kind, right? The second thing you can do is please pick up syringes that you find on the street. It'll save us in harm reduction a whole lot of work if normies just realize syringes aren't dangerous, put them in a bottle, you're gonna be okay. Because that pushback in the community is constant and it's a threat to us providing services. So, you know, if the first thing anyone's like, what can I do to help? The first thing I tell them is pick up syringes when you see them so I don't get in trouble, right? The second thing is just be nice, right? And I guess maybe I have this like seeing the individual as opposed to the system thinking thing happening here, but I think we need to do all of that.
So Kay writes that she does speak and she does help those when she can. And she tries to feed folks there as well. So she just wanted to provide that feedback. Right? So let's see, we have a question from Davidson Weissing. Can it be better if people don't understand, sorry, my dogs are in the background fighting. Can it be better if people don't understand what is meant by harm reduction? Would it be better to have them not know than immediately object to the idea when they hear the words syringe exchange, methadone, or naloxone? How do you get balance not knowing versus stigma against some terms? And Haven, that question came in right when you were talking, right?
I mean, I think it's really tricky, and I think for me, like I know language is very, very important. And I think intent is more important. And so, you know, I think that it depends on the mission, right? And who you're talking to and kind of where they sit. Like if the goal is understanding what harm reduction is, but me saying that word shuts them off to listening, then I shouldn't say it, right? However, if I can get them to understand the ethos and the work and why we do it, and then I can introduce these terms that make people a little bristly, then I'm going to, right? It's just, for me, it's like, what am I trying to get done? Who is my audience? And how are they gonna best hear? My message is gonna be the same, no matter what. But the language I use, I will shift depending. I mean, I think the term harm reduction, I like the term harm reduction, but you know, it comes with some controversy and it comes with some like ickiness and it comes with some like serious exclusion, right? Early harm reduction work was a bunch of cis white dudes. And acknowledging that like, that's, for a lot of people, it has been an exclusionary community. And so, not for all, it has never felt that way for me as a cis white lady, but, you know, I think that, you know, it's okay for some, like, as long as what we're talking about, right? Treating people with dignity and respect, giving them access to tools they need to be healthy and safe. If that's what the goal is, I don't care what words we use. Use any words you want, call it what you want. Similar to like the conversation about safe injection facility versus safe consumption spaces versus like whatever they're calling them in Seattle. Like, it doesn't matter, we're talking about the same thing. And like getting hung up on those things for me is just, it's kind of educational privilege sometimes, honestly. Like, I really do see it as like, I know the right word, you don't know the right word. Like, that's educational privilege. And that is privilege that especially those of us with like letters after our names need to be checking on the regular. So yeah, I don't know if that answers that question or not, but soapbox.
Fantastic. Thank you so much. So Ian Knowles asks, our harm reduction work groups include state people and law enforcement, and he's located in Rhode Island. How do we get PWUDs at the policy making tables with the people who put them in prison?
You don't. You get rid of the people that put them in prison.
And replace them with people who are actively using drugs, because I think a lot of us know that often panels are made up of folks who used to use drugs, but we struggle unless you go to things like, you know, the DPA conference and other things that are kind of more peer led. But for the most part, it's mostly, you know, I was blind and now I can see, and let me tell you about the system that got me there. You know, so those redemption stories need to be sidelined for a little while, and we expand our understanding of recovery and stability.
And then Varsh asks, very interesting panel. Natasha also mentioned utilization of technology and AI in aiding harm reduction. Would like to hear more on that.
Well, I can maybe give an example of something that our team has talked about and might be being developed, but something like, for example, our youth. Since our youth okay, I work with youth who are experiencing homelessness, who are between the ages of 14 to 24, who are disenfranchised, marginalized. They don't access the system for supports and help, and many of them die. You know, and drug overdose is the #1 cause of death for these kids. So we're thinking about, you know, we can identify high-risk neighborhoods and areas that youth might enter. And then if on their phone, we can receive that information where they're located, if they're willing to let us have access to where they are. And then our team receives this information, then we can send alerts to that youth. Hey, you're going into a high-risk neighborhood. You're going into a house where you've used before, and we could send them immediate alerts through artificial intelligence. And then with the response from the youth, do you want to leave? Do you want supports? And then it can trigger different responses, including a live response. So depending on what the answers are, what the situation is, whether it's suicide, whether it's drug use, whether it's high-risk neighborhoods, this is what we're this is some of the things that are going around the country, trying to figure out how to access this ecological momentary assessment strategies to translate that to real intervention in the moment where the kid, well, I work with kids, so I say, but it could work with adults. So wherever they are and whatever the risk is, we can be there.
Very cool. We don't have any more questions in the chat or the Q&A session. So Gordon and Traci, I don't know if you guys would like to wrap it up.
We're looking at each other meaningfully to see who's going to unmute first. The older fastest or slowest draw in the West.
No, this is great. I was just going to say, I think from the questions, which were so thoughtful and coming from community members, coming from researchers, and coming from many different parts of the country. But I think the encouragement to, if you're a student, to get involved with some of the research that's happening, or look to your community for opportunities to be kind. And if you don't see any, maybe you should start making some noise to have the opportunity to breed more kindness. But I guess maybe too, we're representing communities that are are small. I mean, Rhode Island is small, Nebraska is small, like Ohio is big. Okay, fine. But, but in terms of our centers hosting this symposium, we actually are pretty approachable. And I think we have an opportunity to get much closer perhaps to policymakers, to law enforcement perhaps, and to agencies that could really shape the response to substance use and to harm reduction. I'm just going to reflect that. I think in Rhode Island, it really encouraging to see family members really approach the governor and insist that they had a seat at the table at the governor's task force. And in doing so, really have become an important, really, I mean, they've always been an important voice, but a really important work group at the task force, and allowing parents to represent harm reduction, represent prevention, represent better treatment, and to really advocate. So I know there was a question from a parent in our panel forum, and just to encourage the opportunity to keep making noise and while you're being kind. But thank you all for this fantastic opportunity to talk about harm reduction and some paths forward. And clearly we have a lot of hurdles, but I think we're all here to help each other. So please do reach out with, hopefully have each other's contact information from the agenda and otherwise. But thank you all for joining us.
Thanks a lot.
Thank you, everybody.
Thank you all.
Thank you for having me.